computer. Hi guys, nice to meet you. My name is Dr. Sarat Hassan, and I'm here with one of our PRAMS nurse coordinators to talk about the hemolytic disease of fetus and newborn and its implications for nurses in an ICU and why things get done the way they get done, so to speak. The objectives of this presentation are going to be, I'll go a little bit into the basics and I'll talk about what is red cell immunization, what it means, what happens when mom has antibodies against the fetus and neonate, and then I go in a little bit of detail about how testing is done in the transfusion medicine laboratory, the clinical course of HTN, and finally the role of nursing in general, including neonatal nurses, and we will talk also to some degree about the role of PRAMS program. So red cells, antigens, and antibodies. Well, we all know that there are A and B antigens on the red cells, which are naturally occurring, and they have naturally occurring antibodies. And what it means is that when you have blood group A antigen on the red cells, you don't need exposure to another blood group carrying red cell to form an antibody. These antibodies are naturally occurring. So if you are group A or if you have A antigen, on the red cells, you will have anti-B antibodies. If you're B, you have anti-A, and so on and so forth. These are present in the plasma of an infant by 4 to 6 months of life as a result of journal exposure to antigens and as the gut flora begins to develop and comes into effect. These antibodies are usually IgM antibodies, which are larger molecules, and they have like 5 different bits. Like it's like the Ys that you see on the screen, they're like 5 Ys in a circle. But sometimes they can be these small individual Ys or IgGs as well. In addition to the A and B groups or A and B antigens on the surface of red cells, we have about 340 and counting red cell antigens on the surface of red cells. And they're really just proteins involved in multiple red cell functions. The problem with these proteins is that they are immunogenic. So if the body of an individual is exposed to a red cell which has antigens which is different from his own, the immune system of that person can get activated and form an antibody. And that forms the basis of alloimmunization and a hemolytic disease of fetus and newborn. Some of these red cell antigens are expressed very early in gestational age. Some of them are expressed late. As a general rule, the more complex and the larger a protein is, the higher is the chance that the antibodies against that protein are going to be more problematic. So your Rh protein is like big and bulky, so the antibodies are also cause more damage. Blood group antigens are inherited in an interesting way. So there is no autosomal dominant or recessive fashion of inheritance. What happens is 50% of the red cell antigens come from mom and 50% come from dad. So they are co-dominant. So let's say if mom is blood group A and dad is blood group B, depending upon what whether they have another gene or not, the babies can be of any blood group in this case, right? Like they can be O if they got no A or B gene from mom and no A or B gene from dad. They can be AB if they got B gene from mom and D gene and A gene from dad. They can be A positive, A or they can be B as well. This applies not only to the A and B antigens, but also to the antigens that you see on this screen. So they are what we call antithetical antigens. So if the mom has a big C antigen and a dad has a little C antigen, the chances are that the fetus can get any one of these. And that is kind of how the makeup of antigens on the red cells occurs. So antibodies to non-ABO red cell antigens are interesting. These are only formed after exposure to antigen-positive red cells. So for example, antibodies against the D antigen, you will only form if you're exposed to Rh positive red cells or D positive red cells and you're Rh negative. These antibodies are usually of IgG type. And why this IgG and IgM is important, we will talk about that in a minute. So why do we care about this? Why do we care about this so much in transfusion, and why do we care about this in the context of pregnancy and neonatal care? So this is kind of quick and dirty how alloimmunization and red cell breakdown happens. So recipient does not have an antigen on red cells. He gets exposed to antigen positive red cells, usually through transfusion, sometimes through pregnancy. And because of the uniqueness of their own immune system, not everyone does that, but the recipient forms antibodies against donor red cells. And what these antibodies do is that they break down all the donor red cells carrying that particular antigen within the next 21 days. If it is a consequence of transfusion, the individual can have like hemoglobin which is unchanged after transfusion and may have some dark urine, may have some jaundice, all of those things. And this is usually an extravascular process, meaning that this process, majority of it happens in the spleen, or some of it happens in the blood as well. So what about pregnancy? So in pregnancy, fetal circulation begins to develop around 6 weeks of gestation, and as the fetal size increases, the fetal blood volume increases, and as you all know, for a 3 gram baby, they can have as much as 70 to 100 mLs of like the fetal blood volume will be about um, about 300 mLs, right? Because if the fetus red blood cells will carry antigens both from the mom and the dad, and if fetus is carrying red cell antigens on which are different from the mom, then what happens is this. So during the course of pregnancy, as the fetal blood volume increases, there is a lot of mixing between the fetal blood and the maternal blood. And what it does is it activates the maternal immune system and she forms antibodies. Okay. If these antibodies are IgM type, the big 5 size pentamers, that's not a problem because they never cross the placenta from a fetal perspective. But if they're IgG antibodies, they can cross the placenta. And that is where the problem begins to happen. So all red cell antibodies are not created equal. They can have very variable effect on red cells and fetus and neonate, and it's a function of a few things. The antibody type, as we discussed, what is the antigen against which there is antibody? Some red cell antibodies, even if they cross the placenta, will not cause a lot of damage. Some cause a lot of damage, and a common example is anti-D, right? When is a particular red cell antigen expressed on the surface of fetal red cells, and in what quantity? Because that will also be involved in the stimulation of maternal immune system. And then we talked about it, right? Like the complexity or immunogenicity of red cell antigen. So because of that, in transfusion medicine, we have a very good understanding of which red cell antibodies are problematic for pregnancy and which are not. And when we are putting out our recommendations, we are very cognizant of that. So what happens if you have a maternal antibody? Let's say the antibody is formed, but the levels are low. So very little amount enters the fetal circulation. Fetus is not effective. Maybe the neonate will have mild jaundice, in most cases, not even that. So this is the situation where we are talking about for our lab, where the antibody titer is less than 1:64. Antibody reaches a critical level in the mom, which means that the antibody quantity has now increased in the mom to a level where a significant amount of it can cross the placenta and can cause fetal anemia. It is not necessary that it will cause fetal anemia, but it can cause fetal anemia. And it can cause neonatal jaundice and neonatal anemia as well. That is the point where usually people are referred to maternal fetal medicine. And if the antibody is IgM, it cannot cross placenta. And hence it has no consequence for the fetus. So how does it affect fetuses and neonates? And that is the aspect I think you guys know pretty well. So I'm hoping that that shouldn't take so long. So impact in the fetus. So when mom has an antibody, it's crossing the placenta, it's getting into fetal circulation, and it's causing the breakdown of fetal red cells. Over time, they're gonna have anemia, and with the anemia, they have a lot of cardiac compensation. So they have their cardiac output increases, the fluid shifts happen, and eventually, if it is untreated, it leads to what we call the right heart failure, high output cardiac failure, and that causes fluid buildup in everywhere in the body. So like I don't know if you all have a lot of experience in seeing hydropic babies, but I know for a fact that they happen here and there. And they happen because the heart fails. And then you have, or you have significant cardiac dysfunction because it was overworking. And that leads to fluid accumulation in the belly, in the limbs, everywhere. And they are these big babies, right? And then obviously, because you're anemic and quite significantly anemic, depending upon how bad this is, your brain development can be affected, and you can have CNS ischemia, and you can have that. To prevent that, what we do is as follows. So in this slide, when I talked about, so when antibodies reach this level and and they have consequences, and they're clinically significant from a pregnancy perspective, these patients are referred to the maternal fetal medicine. Okay. And then what maternal fetal medicine does is that it begins to perform weekly to every 2 weeks Dopplers of the fetus and looks at the flow of blood in the middle cerebral artery. And if that flow is increasing and increases to a significant degree, then the fetus is deemed anemic, and then these pregnancies and these pregnant individuals get shipped off to either Winnipeg or Toronto or Calgary, and they get intrauterine transfusions. And these patients are then usually delivered before 38 weeks gestation, because after 38 weeks, the MCA Dopplers are not reliable when it comes to determination of anemia. So this is what's happening on the maternal side. Okay. So what happened on the neonatal side? So when the fetus is in the maternal environment, when in the uterus, the placenta and the amniotic fluid can get rid of bilirubin. So bilirubin is not a big problem at that point. Once the baby makes their way out, they're having hemolysis, they have an immature liver, and there is no placenta to remove excess bilirubin. So that bilirubin can cross the blood-brain barrier, as you all very well know, and then it can cause damage to the CNS and can lead to bilirubin-associated cerebral palsy. In addition, the neonate can have anemia, right? And that anemia can go on for as long as the maternal antibody is hanging out in the plasma of the baby. And that anemia can have consequences, right? This anemia can lead to ischemic damage to the brain. This anemia can lead to heart failure if it's happening over long periods of time. And then sometimes, depending upon the type of antibodies, you can have even the production of red cells, which is affected. So I want to take a minute and talk about the way these antibodies can affect and the interventions that we do can affect the fetus and the neonate and the type of anemia they can have. So most of the antibodies, like the antibodies against the Rh blood groups, antibodies against the Duffys, antibodies against the JKA system, they usually cause hemolysis. So you're going to have high bilirubin, you're going to have red cell breakdown, and then you can have heart failure over time in the fetal environment, all of those things. Anti-Kel antibody, however, is unique because it suppresses the production of reticulocytes or the precursors of red cells. And so it causes like an anemia, which is not a destruction problem, but it is a production problem. So, and it can stay for a long amount of time. Another interesting thing about anti-Kel is that anti-Kel is one of those antibodies which, for which we do not have a good way to know which quantification or which teacher is critical. So if we see anti-Kel, we send the patients to MFM and they get middle cerebral artery Dopplers for determination of whether there is neonatal anemia, fetal anemia. Intrauterine transfusions also kind of stunt the marrow of the neonate of the fetus, so they stop making red cells for a small amount of time, and then after birth, like after first 4 months of life, it begins to recover. In very rare cases, if the antibody is very immunogenic and at very high titers, I have seen that anti-D or anti-little c. So anti-D, anti-little c, and anti-Kel are your worst actors. The rest are relative, cause HTFN, but it tends to be relatively less severe. But these three are really bad. And sometimes the anti-D or the anti-C antibodies are so strong that they can also destroy the red cell precursors. But that is very rare. It's not very common. So I want to talk a little bit about intrauterine transfusions, because these are the patients that you may receive and they will look completely healthy. And you will be like, okay. So when intrauterine transfusions are given, usually there won't be a lag of more than 4 weeks between delivery and an intrauterine transfusion. Sometimes it's less than that. So this kind of give the message to the neonatal bone marrow that, hey, you don't need to make red cells. You're getting all the red cells you need. So the bone marrow gets stunted and the production is affected. On the top of that, whatever the neonate is able to make, that is destroyed because maternal antibody is still present at a very high level in the plasma. So at birth, if these babies had received an intrauterine transfusion within the recent 3 weeks, they can look completely normal. They may not have jaundice, they may not have anemia, they may appear like they're completely fine. But then they will come back between 4 to 8 weeks of life and the donor red cells have died off with profound anemia, like hemoglobins in 50s, in cardiac overload, all of those things. And that can lead to a lot of panic. The other issue is that when you do cord blood testing for these particular individuals, because they have received intrauterine transfusions and most of their blood volume is donor blood, that testing is under that. But we have done enough genetic testing and all of those things in the prenatal period that we kind of know for sure what we're dealing with. So most of the infants, if untreated, unmonitored, are going to get profound anemia within the first 2 months of life if they have received intrauterine transfusions. This anemia can continue up to 4 months, and this is the group where we preferentially give erythropoietin or darbepoetin for the first 2 to 3 months of life to wake the marrow up and to stimulate the red cell production, because now there's data that says that that it does reduce transfusion requirements and it reduces the course of red cell production issues after delivery. So this is kind of the 3 things. Sometimes these babies will be born and they will have hemolysis. They will have jaundice and they will have anemia because the antibody is so strong that even though there has been donations going on, it's just not been able to completely stop the process of hemolysis within the fetus and the neonate. So it can happen in any one of the ways. And it's important for you guys to know that, especially in the context of a normal baby with no anemia or jaundice after intrauterine transfusion. So that brings us to transfusion testing in neonates. And after that, I will talk about the complete course of the hemolytic disease of fetus and newborn. So when we talk about transfusion testing in neonates, so what does it include? So number one is everyone's favorite, DAT. So what is DAT? DAT is just looking at antibodies which are sticking to red cells. And that's all it's doing. It can be positive with any maternal antibody. Just because you have a positive DAT does not mean that you have hemolysis, though in the context of clinically significant red cell antibodies, a DAT will usually be positive when the mom's antibody titer is higher than 1:64 or at least around 1:64. And those babies will have at least some jaundice and evidence of hemolysis as well. Okay, DAT, antibody screen. Antibody screen is when you're looking in the plasma of the neonate or the mom to see if there is any antibody present. Okay, and that is the test which is done very early in the pregnancy and in the mom, and it helps us determine if there is any antibodies. If we don't know the kind of antibody the mom has, we can do this test on the neonatal plasma and we can figure this out. And then you know what a cross match is. Cross match is when you're taking the donor red cells and you are mixing them with the recipient's plasma and you're trying to see if there is any reaction or agglutination, because that will indicate there is an antibody present. And this is important to do before we issue blood for our neonates in the context of maternal alloimmunization. So when you have an alloimmunized mom and we have a neonate who is going to need exchange transfusion or who is going to need a red cell transfusion, we make sure that red cells that we are giving are antigen negative against which there is antibody, but we also test the cross match to make sure there are no reactions. The other thing which I think is kind of important from an NICU perspective is what tests can be done on which specimen, right? So DAT can be done on anything. It can be done on a cord specimen, on a capillary specimen, and on a venous specimen. And that is also why a lot of Healthy and Home like our Healthy and Home program will use capillary specimens for DAT testing. Antibody screen can be done on neonatal venous specimen, cords, as well as maternal specimen. If you are unable to get any specimen from the neonate and you don't have cord blood, you can use maternal specimen drawn just within the previous 2 to 3 days to look for antibodies. Because at this point, the baby's immune system is not going to make anything. It's any antibody which is hanging out in the plasma of the baby and is causing badness has to come from mom. Red cell antigen typing can be done on anything, cord blood, capillary, and the venous blood. When is it done? So if mom has formed an antibody, let's say an anti-kill, then, and let's say through the pregnancy, she does not require any transfusions, and we did not determine then when the baby is born. So what we do is we type the cord and we see if that is antigen positive or not. If it is antigen positive, that is the only point when the baby will be at risk for HD, and otherwise it will not. Cross-match is something which also require either a neonatal, like a venous specimen, or the maternal specimen to allow for issuing safe and compatible units. So when is cord blood testing done, right? So cord blood testing is done automatically in the transfusion medicine lab, and this includes DAT, blood group A and B status, RH status, red cell antigen typing, and antibody screen. That will be done if we know that mom has antibodies. That will also be done if we hear back from the MRP of the mom that there was no prenatal care in the mom, right? Sometimes what will happen is cord blood testing and maternal antibody screen will be getting done simultaneously. And in an RH negative pregnancy, the value of cord blood testing is to figure out if the baby is RH positive or not. So if the baby is RH positive, the mom gets Vinro, otherwise she doesn't get Vinro. The other value of DAT is obviously determining if there is hemolytic anemia going on, and we kind of don't know what's happening. So baby is coming in, he has severe jaundice, he has anemia, there is no obvious reason. Either we don't have any maternal antibody data, or maternal antibody data is not proving to be helpful. You definitely can request DAT. Same goes for jaundice. So if it's severe jaundice, which cannot be explained by other reasons, because as we all know, jaundice can be caused due to many things, or if it is hemolytic anemia, which cannot be explained by other things, DAT is very appropriate to be done in the neonate. It may not be able to get done on a cord, because cord is usually thrown away within the first 2-3 days, but a capillary specimen or a venous specimen is appropriate. I want to quickly talk about the comments that you will see on the cord blood testing, and just to be mindful that this is kind of what they look like. So let's say you have an alloimmunized mom and you have an antigen positive neonate, and the cord blood testing is performed and the DAT is positive. So it will say DAT is positive, most likely due to maternal antibody, anti-D. Unit is positive for D antigen, risk of HDFN, consultation with NICU is recommended. Okay. If the neonate is not antigen positive, if the neonate is antigen negative, we will say neonate is negative for X antigen, it's not at risk of HDFN, we do not need to test for it. And if the mom is alloimmunized and neonate has a positive antigen, but the DAT is negative and the antibody level was low in the mom, then we say something to the effect that risk of HDN is low, but please watch for jaundice. And if jaundice happens, that is the point that please do consult peds hematology or NICU or pediatrics as indicated. So these comments exist for any healthcare provider who is going to be receiving the delivered infant, including before they actually make their way to an ICU. But I think it's important that you know that this is provided in our cord blood interpretation results. So clinical course of HDN, clinical course of hemolytic disease of newborn depends upon a few things, right? It depends upon the kind of antibody, whether the antibody is suppressing red cells, whether the neonate received IUT, and then how long does an IgG antibody stay in the plasma? So half-life of an IgG is anywhere between 18 to 21 days. So it takes about 84 days for it to drop like to very low levels within neonatal, within neonatal and infant circulation. And in all this time, the neonate is at risk of anemia. Obviously, that risk is higher in the first 21 days when the antibody levels are very high. But then as the antibody levels begin to go down, the neonate, the risk of anemia lessens. A critical point that happens is about 42 to 60 days of life, because that's also the time for physiological hemoglobin nadir, which happens due to changes in the environment from fetus to a newborn and changes in the hemoglobin type. So everybody has a drop in hemoglobin at that point. Even a normal infant will have it, but then it will be much more severe for somebody who has another pre-existing cause for hemolysis. So jaundice monitoring is usually required in the first 2 to 3 weeks of life. After that, liver is maturing and that is not an issue. Anemia monitoring usually requires up to 4 months, but it becomes a lot less intense after like the first 21 to 42 days, unless it's a patient who had received intrauterine transfusion. So I think this kind of provides an overview of what happens in the peds hematology realm. It kind of provides an overview of the antibody testing and what do different antibodies do. I'm gonna now pass over to Shilin, who is our PRAMS nurse navigator, and is responsible for the care of alloimmunized pregnancies and being a coordinator there, as well as in the immediate neonatal period. And I'm gonna mute myself.
Thanks, Dr. Tassine. My name is Shaylin. I'm the nurse coordinator out of Saskatoon for the PRAMS program. So I'll just talk to you a bit about our roles in regards to alloimmunization. So first of all, just what is PRAMS? Briefly, it stands for Prevention of Alloimmunization in Mothers of Saskatchewan. So who are we? We're a working group of transfusion medicine physicians. We have 3 nurse coordinators, one in Saskatoon, one in Regina, one in Prince Albert. We have some MFM specialists on our team, as well as lab specialists. And basically, we are a quality assurance program designed to streamline and ensure cohesive management of care for both Rh negative and allo-immunized pregnant women in Saskatchewan. So some of our goals include ensuring consistent, timely care across Saskatchewan. So this is in regards to titers for these antibodies. We make sure that they are monitored every 2 to 4 weeks throughout the pregnancy, depending on gestation. We also are responsible for making or monitoring that patients get WinRho if they're Rh negative throughout their pregnancy. We also follow up with newborn follow-up in these allo-immunized patients. We provide educational opportunities for nurses, physicians, rural centers, northern outpost stations. We've developed educational materials for patients in regards to Rh negative status or allo-immunization. We ensure referrals to those MFMs when needed, as well as OBS-GYN if required. And as Dr. Tassine mentioned, we ensure that that newborn referral to pediatric hematology has been made for those critical titers. So I have just a couple clinical cases here I just thought I'd bring up quickly. So this patient, RP, she had a pregnancy in 2020 where she refused her WinRho for personal reasons. She was Rh negative. She did go on to develop an immune anti-D, which became critical in her next pregnancy. She had a titer of greater than 512 at 20 weeks gestation in her pregnancy. So we ensured she was referred to an MFM who monitored her with the MCA Dopplers. Unfortunately, she did go on to need IUTs. This patient was sent to Toronto. She received 3 IUTs throughout her pregnancy. Once delivered, this newborn received IVIG, phototherapy, and blood transfusions for severe hyperbilirubemia and anemia. The other case I wanted to bring up was this patient TP. So she actually had an initial prenatal screen that was Rh positive, and she had a negative antibody screen. And during pregnancy, she somehow developed this anti-FYB. She had a group and screen at the time of delivery, and she had an anti-FYB show up with a titer of greater than 512. So cord blood was tested, and baby was positive for that FYB antigen with a positive DAT. This baby went to NICU and was treated, as well as had ongoing anemia later on. So received 7 weeks of age, she received a blood transfusion. So this just is a basic handover and communication post-delivery. So multiple players are involved. So first off, there's a new or known significant antibody at critical titers. So that we ensure communication between the roster physician, pediatric hematology, and NICU is happening. If the baby's admitted to NICU with this critical alloimmunization, this is when we ensure that the pediatric hematology is consulted and they're in contact with those NICU doctors. If the baby is a recipient of IUT, there's the communication between an MFM and NICU prior to delivery so that they are aware. And then postnatal follow-up for infants till the anemia is resolved. So that's done by pediatric hematology and general peds or family physicians as well.
I'm just going to comment that for our IUT infants, they are a part of our bi-weekly PRAMS round. So these mothers who are recipients of intrauterine transfusion, we follow them very closely because the consequences both for the neonate are more, and they require more monitoring. So we are very closely aware of those. And if we feel and if there is any gap in any of these points, for example, MFM communication didn't go to an ICU for some reason, PRAMS and nurse navigators become the stopgaps, and they make sure it's happening and it's not missed. And the postnatal follow-up of infant still anemia resolution, if it is an NTD, C or KEL, or if the neonate received any transfusions in the NICU or has other issues going on, had IUT, then it's usually peds hematology directly. For others, we work very closely with whoever is the care provider for the baby to make sure they're following the labs, and if anything is going on, then we advise them appropriately about anemia.
Good, thank you. Here's just some links. So we have our SAS Blood PRAMS website with a lot of our teaching on there, our algorithms, our FAQs are all on there, as well as we're working on getting more information up on the Moms and Kids website as well. And of course, our email there. If you have any questions or anything, feel free to reach out.
Okay. I will say that since this is recording, I don't know what questions you're going to have, but if you have questions, just send an email to either one of us and we will be happy to answer them. And if there are too many questions, one of us can actually come and talk to you guys as well. Thank you for listening. You guys have a great day. And
Thank you.